So we're fortunate enough to have with us today Randy Linthicum and Erich Bonny. Randy, I've known for a long time, have tremendous respect for him. He's Director of the Emergency Operations at Maryland Institute for Emergency Medical Services, and he directs the agency's preparedness and response activities, and he coordinates the state's critical incident management team. Randy, before he came to Maryland, and Randy, I got to ask you what you were thinking, was in California, of all places. That's really where you become a disaster expert in some ways, I guess, where he spent several years directing as the chief of the Disaster and Client Services Bureau. Erich Bonny has over 30 years clinical experience in mental health, providing services both inpatient and outpatient services. He's a founder and therapist at Cedar Ridge Counseling Centers, and he's part of the critical incident stress management team for the state of Maryland Emergency Medical Services. We have to have a reach out, shout out, as they say, as the kids say, to Dr. Rick Ottenstein, who was originally part of the presentation, recuperating from some surgery. He is here, will be part of the later presentations, but he is a part of the team. They are there here to share with us their experiences in the Virgin Islands, so I thank you for being here.
Good morning. So Erich and I are going to talk about a kind of unique mission that took place in the U.S. Virgin Islands. I'm going to talk a little bit about the structure that was utilized to deploy us, the Emergency Management Assistance Compact, and a little bit how the mission came to be, and then Erich will talk about some of the details on what we did in the Virgin Islands. Just as a background, this map isn't to scale, but as you can tell by the name, and you already know, U.S. Virgin Islands is a U.S. territory. It's very close to Puerto Rico and the Caribbean. It's made up of 3 larger islands, St. Thomas, St. John, and St. Croix, and some smaller islands. About 100,000 people, plus or minus some. Most of the population is about half on St. Thomas, half on St. Croix, and a lesser amount spread on the smaller islands. In 2017, like Puerto Rico and Florida, the Virgin Islands was hit by hurricanes. In their case, both Irma and Maria were Category 5 storms. They didn't get as much press as Puerto Rico or Florida, but they were just as devastated by the hurricanes. Many homes were destroyed, businesses damaged and closed, many permanently, power outages, internet outages, some of those very long-term cell service outage, medical evacuations. Dialysis patients, for instance, and other medically fragile patients had to be moved off the islands, many of them never to return. And also many people just gave up and left for the mainland, and many of them didn't come back. Even prior to the hurricanes, the economy wasn't doing well in the Virgin Islands, so many people had started to leave. The population was already dwindling, so there were already stressors in place prior to the hurricanes. Just a side note, after these devastating hurricanes took place, the governor of Maryland, Governor Hogan, strongly encouraged all state agencies, including mine, which is the state EMS agency, to support those devastated territories and states in any way possible. We normally try to do that. We've sent ambulance strike teams and personnel to other states in the past, but having the governor push that really gave higher level support in my agency and other agencies, and helped with this and other missions. So 4 months after the storms, they were still making requests for support in the Virgin Islands. They made a request for mental health support for government workers and first responders. Their thinking was the government workers were working, they had compassion fatigue, they'd been working long hours for months following the hurricanes. Many of their coworkers had left, so they were short-staffed. They had a lot of stressors, having their own homes destroyed, and a lot of other things going on. Same with first responders. So they requested 15 licensed mental health providers and 2 team coordinators to come and support them for 21 days. And the request was made through the Emergency Management Assistance Compact. And I'm going to cover just briefly what that is, how it works, and some of the strengths and challenges of that system. It's basically a nationally accepted mutual aid agreement that all 50 states and most of the U.S. territories have ratified. It's been ratified by Congress, and it's a mechanism to share resources between states during governor-declared disasters and emergencies. The bottom line on the slide is one of the important factors. It works out in advance. It's all in the Act. Tort liability protections, workers' comp, license reciprocity, reimbursement. That's all spelled out in advance. So for instance, my Maryland paramedic license, if I go to Texas or another state in an EMAC mission, I can function up to the scope of my Maryland paramedic license in any of those other states without any other additional paperwork, training, or reciprocity process. So it really speeds the deployment to a disaster. So basically how it works, the impacted territory or state, in this case the Virgin Island, identifies what they need. In this case it was 15 mental health providers. They determine what they need, how long they need it, what needs to come with it as far as supplies and logistics, and then they enter that into a national system. It's an online system, and that's blasted out either nationwide or to selected states. In our case, the mission was disseminated nationwide. Other states then see the request and they determine, based on their state, working with local partners and others, are we going to try to respond to fill this mission? So the states that put up offers for the mission enter it back into the system, and then the requesting state decides which mission, which offer they're going to accept. They could potentially get 20 different offers of assistance to fill one request, and then they need to pick the best one that works for them. Sometimes it's the cheapest one, sometimes there are other factors. So then paperwork is completed. Once the mission is accepted, approval is done on both sides, and then the mission takes place. The sending state is responsible for tracking all expenses and submitting a reimbursement packet afterwards, and then the requesting state is required to make payment and pay for all the services they requested. They're responsible, but they normally have FEMA assistance with cost recovery. Some of the strengths of this system, again, it's widely accepted and routinely used across the U.S. It's used during every large hurricane, another large event, and it's used for everything from public works, ambulance, fire personnel and equipment, and in our case, mental health CISM support. And it really enhances the ability to share resources. Again, I mentioned workers' comp, liability, and using out-of-state professional licenses. If a team just deploys to another state without a formal mutual aid agreement or without this type of arrangement, there's obviously things that could make it get messy. If the responding personnel get involved in a lawsuit or get hurt, it's going to be murky on who's covering what. So this takes care of all of that in advance. Challenges of the system, it's usually a very short time frame to respond. The disaster site, the requesting state usually wants resources fast. Often they want resources on the ground within a few days or the next week. So it's a challenge to cobble together the response and get everything done to meet that time frame. It's also possible that a state could get multiple offers for the same request, and we've had this happen to us. So you could do a lot of work cobbling together a team, making it available, and doing a lot of upfront work, making the offer, and then have another state's offer accepted. So that happens quite a bit, and it's a challenge of this system. It also requires communication with the person writing the request. Often these requests come in, they're just like a 2-page piece of paper saying what is requested, how long it's needed, but there's not a lot of details. So sometimes it's not clear exactly what they're asking for. So in our case and in other cases, making direct contact with the person who wrote the request to really understand it is critical. And again, as a sending state or a sending organization, you're responsible for a lot of costs up front. In our case, it was airfare, some of the lodging, the feeding for our personnel. That's all at your expense. You're reimbursed for it, but the reimbursement process is very slow and could take up to a year, sometimes longer. So that's a challenge, especially on the private sector side. We sent some independent and and small business licensed mental health providers who took time away from their practice, gave up salary for, in our case, up to 24 days, and then were not paid, not reimbursed for a full year afterwards. So that's a challenge that they're aware of at the national level. That's a big challenge. And then again, the sending state needs to bring and ensure the logistical needs of your responding personnel are met. Some of that takes place with good communication with the person making the request, but you need to be ready to take care of your people once they're deployed, because it's not always done in advance. So in our case, the request came in to our State Emergency Management Agency. We had some direct discussions with the person who wrote our request. In our case, it was written by the mental health director from New York City, who was already on the ground in the Virgin Islands assisting them with mental health recovery. He had written our request, and he had written it for 15 licensed mental health providers. My agency is a state EMS agency. We don't coordinate mental health. That's done through the Department of Health. They were not willing to participate or to try to fill this request. So I talked to him to see if we could potentially send a mixed team of CISM trained peers and licensed mental health providers. Rick Ottenstein is our clinical director, became the clinical director of our team. He also had discussions with that individual. And we basically convinced him that a mixed approach, CISM and trained mental health providers working as a team, could meet the needs of what he was requesting. So the EMAC request was refined, re-entered, we responded to it. We did all the background logistics, lined up the team, and we received the approval for our mission. So again, why a CISM team rather than just a share mental health team? First of all, my agency, as I mentioned, is a state EMS agency. If it was only mental health, we probably would not have been the ones coordinating it. And really for an EMAC mission, you really need a state entity that's helping to coordinate and to push the mission. So that was one factor. Another one that was the biggest factor is that we had done this before. We had coordinated a joint mission of licensed mental health and peers that worked together, also in response to the same hurricanes following Irma. Florida had been devastated, obviously. They requested a mental health team for shelter workers and other populations. We ended up sending a mixed team to that response. Erich was actually on that mission as well. That proved very successful, so we knew the model of a mixed team would work, and that's the main reason, one of the main reasons. It also gave us better access to emergency services. One of the populations to be served by this mission were first responders. Having a mixed team of fire EMS peers going alongside mental health into a fire station or a police station, we knew would probably be better accepted, and that proved beneficial. So the actual response, we responded January 23rd to February 14th. We served all 3 of the main islands. We ended up sending 17 personnel, 8 from Montgomery County Fire and Rescue. They provided all the peers, and 8 licensed mental health providers, and I went as a state coordinator. We ended up having all of the team were cross-trained as CISM, so instead of 15 people and 2 coordinators, we basically sent a 17-person team and coordinated also. And we provided support for government workers and first responders, and Erich will get more into that. Just to demonstrate how quick a turnaround this is, we were notified of the request on January 17th. We had people on the ground in the Virgin Islands on the 23rd. We were initially stationed on cruise ships, which obviously very good living conditions for a disaster site. FEMA had rented cruise ships to house emergency and responding personnel. No other place on the islands for them to stay, so it made sense. The initial assignment was for us to conduct multiple 4-hour training sessions throughout the islands. We were told by the Virgin Islands personnel that they would line up who would be at the meetings, they would line up the venues. All we had to do was show up and do the training. As Erich will mention, that really didn't work out that way. First 2 days of our time on the ground was spent meeting with the outgoing New York City behavioral health team and other officials in the Virgin Islands. One thing that happened just shortly after our arrival is there was a line of duty death in the fire department on St. Croix. A firefighter had a heart attack and died on scene of a fire. We were fortunate that two of our advance crew were the leadership of the Montgomery County Fire Rescue Team. They responded and they visited all of the firefighters that day, met with the chief, and were really well accepted and became really key partners to those firefighters in the recovery process. They assisted with the funeral and responded and worked with those personnel the whole time we were there. This event was obviously very unfortunate, but it did give us credibility from the start and really helped our team get accepted into that island and others.
Thanks, Randy. I had the opportunity in being in Florida before, so this is interesting because I had the same Irma hurricane that was hitting there. I was there 1 month after that, though. There I was there as a mental health lead, and then I had two teams of peer responders, one from Howard County and one from Montgomery County. So it was different, 1 month after, and here we are 4 months after. And we were trying to work out, how do we get this going? Well, we found out it didn't go that smoothly. You know what happens when you get on the site. And when you're on site in a natural disaster, I'm afraid things don't go smoothly with communication issues. I had two phones, one from my home, one for the network on the island, just to see which one would work, what day it was. Internet would be up and down. Communications with government people were difficult. So the first meetings were really no-shows, or we relied on their organization and it didn't quite happen. So we had to start redeveloping what was going on. We also realized that with this, we had to look and really get to these people on site. They were just, relocated. Their office was destroyed, so they were somewhere else. We had to see what equipment we needed and whether they had it or we needed to have it brought in. Randy helped with that. We had these miniature little projectors that we used for our PowerPoint as we traveled around to different sites. So working with them, and another way that I found was very helpful is you just go and meet them. When you can't reach them and you can't get the communication through, you just show up. And showing up made a big difference in getting things rolling. There was a reorganization in the sessions, and because of that, we found that 4 hours was much too long to really try to do anything with folks because it was an extended period of time. We were looking at how can we work with them and get them through a process that may bring out some affect, as in the CISM model, CISD model in general, but it was more difficult because we had to rethink how the model would be applied. So that was part of the process too. When we came together to do the original presentation, we used subgroups of everyone in our teams, brought that together with the help of Dr. Ottenstein, bringing it together in a PowerPoint, reducing that over time, refining it. So there was a lot of adjustment and trying to tune something to what was going on in front of us. So the new sessions were 2 hours or maybe 1.5 or so, and that was something that we could work with much better, and it seemed to work. And trying to get to people on site instead of trying to draw them to sites that were difficult for them to get to. On the side of a hill, we had a school up on the side of the hill there in St. Thomas. So there wasn't much parking there. You had these roads that go in and out. So in reality, we had to find central locations, like at an auditorium or other sites that we could draw people to. Part of it also was developing the scheduling. We had to meet and connect with as many people in the government there as we possibly could. So Dropbox worked out well, using that to schedule because Randy was on one side of the islands with Rick. They were on St. Croix. I was on St. Thomas and St. John. with Stacy Daniel, the battalion chief from Montgomery County. She was over fire, I was over mental health there. So communicating between islands, which is a 45-minute flight anyway, is difficult in trying to keep things organized and flowing as best we could. So then the program got developed. There were many, in the end, formal and informal situations, because we also drew on island folks who would like to talk to us to draw information, what would work best. How can we customize what we're doing to work best for the people involved? And so we had a whole range of different agencies that we needed to work with, and that made a big difference too. So the model changed, and we kept redeveloping it into the night as we needed to. The 2-hour sessions were there. The training focused on current response in their state of recovery. When I was in Florida, it was 1 month, much different than 4 months later. And how do you intercede? How do you intervene with people 4 months after an event? Well, part of our purpose in the mission was to help all the government employees, including first responders, to prepare for the next hurricane season. So we're working really on an anniversary issue in a way, and working them through and helping them develop ways of coping as the next one was coming. Because the reality was there was an exodus of many people, and many didn't come back, and the government was losing all of their employees, more or less. So that was part of our focus there. So the training provided by peer and mental health teams. What I think is great about having a group of very professionals, is what I like to say, is that each has their own skill and strength and can be drawn upon to approach different populations. One of the realities of working with Dr. Ottenstein in the Workplace Trauma Center is that we work with a lot of corporate settings. We work through HR, we do presentations. So a lot of the people in the mental health end of this had training in doing presentations. Peers did too, but they didn't know if they were comfortable doing it. But we would pair up, and there are some photos showing that. But there are also, I could use peers on the side, and they would bring their anecdotes in as I was giving the talk on the PowerPoint, and it would really made things go smoothly because everybody had a piece, but when we would go to a fire station, they would take the lead. Sometimes it was more mental health, or we worked with a hospital center there, mental health may take the lead. But you share, it's collaborative, that's what I liked about it. And same thing happened in Florida. So both of us did the trainings, but they varied, would be one-on-ones, there's a range of different things that we would do to help them move through. So this is the interesting part about the training. Usually in the CISD, teaching isn't first. It's a little bit later in that process. But I like what Jeff Mitchell says, adaptation in the setting that you need to. So in being able to do that, we actually shifted it around to actually teach to draw out affect, to bring out the feelings that were remaining, because 4 months later. So this is the PowerPoint. Started as behavioral health recovery. We didn't think that would work well. So moving forward is something we came up with. That was what our team name was, and what we had on our communications also shared that too. This gives you a general idea of what the PowerPoint was like from start to finish, and we used this in all these different settings, shooting on the walls as we needed to or wherever we could to help to get the message across. Change happens, the effects of trauma, a little more education there to a certain extent, but then we're going to get into stress reduction techniques. I did a deep breathing exercise for them to help experience relaxation technique, to help them move through that. And then, of course, last but not least, is resiliency. And one of the slides we use with that is right here. To give you an example, I like the part about danger and opportunity and redefines life. Discover who you are. In a sense, 4 months after, they had survived, but we wanted them to tie into the qualities that they had to move towards the next hurricane season that was coming up. So resource development. How do you draw on things when there's been devastation on 3 islands and things seem to be pretty limited from what we could discover? So you really have to draw on a lot of different resources, whatever you can think of. Part of the reality and part of the work I've done with workplace trauma and others who were there is we do trainings for a lot of employee assistance programs. And there was Cigna, which is a large national EAP. We actually work for them anyway in the States, but here we were again, and we could use the resources of the employee assistance program and even handouts that they had, which I'll show you here in a minute. And also one that Randy had set up too, that, let me just show you that. Here's one showing, these are the realities of what can happen. These are some of the things you can do. But we went beyond that too. We also captured those that we could get from the employee assistance program that were available to us too, and used those too. Another one here, and especially I want you to look at right here, I think that URL that you'll see down there is what was put together while we were there, so they could tap into a URL with a whole list of all our handouts, contacts. You'll see SAMHSA on here, of course, too. And with that process, they had a range of things that were either local, which was quite limited, or they could reach out to more national connections that they could do electronically to talk to others. I'll also say one of the big issues in the islands is confidentiality, a big one. How can you talk and, gee, your neighbor and the guy right over the other side of the hill is somebody I know? Well, the reality of the EAP is that you can call an 800 number, and they're not going to be on the island at all. So we try to tap into things we could think of as we went along. So these is a range, of agencies that we really had. Try to think of the spectrum of this, from first responders to utility people, to the governor's office, to WIC, to all these different school administrations. We try to cover as many people as we could. Part of that process actually was shown back here. You'll see as another communication what we developed, along with trying to help them develop communications for their employees, like we actually did in Florida too, to help them capture people, not scare them away. This is one that Randy had with his name on it here. I have one for mine because I have my own phone number for the other islands. So Randy was scheduling on St. Croix. I was scheduling on the St. Thomas and St. John. So, what about the lessons learned here? What do you think we figured out? The realities are there. In the end, put together a good, balanced team. People with a lot of different skills. Those who apply to logistics, to communications, IT people, which we had there too, and having a spread of those people in your teams. That always will help with a variety of conditions, even in teaching, which we were kind of basically focused on. So, team development. In the talks we're going to have this afternoon and tomorrow, I'll talk a little bit more about this. But how do you develop teams? How do you get cohesion? We have splitting that happens between peers and mental health. Have you seen that before? I would think. But in reality, there is a nice blend that you can create. But I even made extra efforts to help mental health people sit at the table of peers and things like that. Little things that you can do to develop a team over time. So as I was mentioning before, also drawing on those potential site resources, using them whenever you can. and those strategic things with the trauma phase. Where were we here? Were we right after the event like I was in Florida? No. We were there much later. Things had gotten entrenched, if you know. These people were getting into PTSD at that point. And reality is they needed to know that and find ways to move beyond that as best they could. One example I had was in DSS. I was there and I was projecting on the wall. There's one small window. When suddenly the wind came up and it got dark. Everybody around me went right to that window and they were waiting. But, you know, that's what PTS does. It wakes it up in you. And that's where they were, but I was able to use it in the talk anyway to help them move through that. So teach first to get target processing. Teaching to draw out things at times is a way of doing it and connecting with folks and bringing that information forward. So we were in a mix of not really diffusing in some ways. In reality, these people had repeated devastation and impact. They didn't go home, or they had a home, or they had an office with mold in the ceiling. The hospital had mosquitoes growing in water caught in a plastic in the ceiling. You never know what you're going to run into, but these are just some of the realities that are there. Randy.
Okay, last slide. All right, just some quick lessons learned from the EMAC perspective. Again, you have to be prepared for a quick deployment, put a team together quickly, a lot of work in a short amount of time. Have to be flexible. The initial description of the mission is not always what you're going to end up doing. That's true of any disaster response. Sometimes that's frustrating to the people that deploy. They think they're going to do one thing. They end up doing something less glamorous. That's something to keep in mind and to prepare your teams for in advance. Always send an advance team to prepare mission response and logistics. We did that in this case, but we were only there basically 2 days in advance. We needed a lot longer to work out some of the bumps that came up. Be prepared to handle and pay for your own logistics, and then understand that the reimbursement process is going to take up to a year, sometimes even longer. Erich mentioned we have a couple other sessions on this trip coming up. Rick Ottenstein will join us for that, as well as Stacy Daniels will give a more in-depth perspective on the fire EMS response. There's one of those this afternoon and another one tomorrow. Those are both the same session, just offered 2 different times.
Thank you, and I want to also stress, take care of yourselves, and I'll be talking about that a little bit more in our presentation.